Gastroesophageal reflux disease. Adriana S. Sanchez, MD. Fozia Akhtar Ali, MD. Basics. Description: changes of the esophageal mucosa resulting from reflux of gastric contents into the esophagus, often described as heartburn, acid indigestion, and acid reflux. Epidemiology. Incidence 5/1,000 person years. Prevalence 10-20% in the United States. 40% of adults in the United States have reflux symptoms. 50-85% of gastroesophageal reflux disease, GERD, patients have non-erosive reflux disease. Chronic GERD is a risk factor for Barrett esophagus. 10% of patients with chronic GERD have Barrett esophagus. Risk of adenocarcinoma without Barrett esophagus and no dysplasia, 0.1–0.5% per patient year. Risk of adenocarcinoma with Barrett esophagus and high-grade dysplasia, 6–19% per patient year. Pediatric population, regurgitation occurs at least once a day in 2/3 of 4-month-old infants, decreasing to 21% at age 6 to 7 months, and 5% at 10 to 12 months. Etiology and pathophysiology. The pattern and mechanism of reflux varies depending on the severity of disease. GERD begins when acidic stomach contents contact the squamous mucosal lining of the esophagus, at the esophagogastric junction, EGJ. Inappropriate transient lower esophageal sphincter, LA, relaxation. Foods that are spicy, acidic, and high in fat, caffeine, alcohol, tobacco, anticholinergic medications, nitrates, smooth muscle relaxants affect LA relaxation. Patients with severe GERD often have evidence of a hiatal hernia, which can trap acid in the hernia sac, impair acid emptying, increase retrograde acid flow rate, reduce the EGJ sphincter pressure, increase frequency of transient LA relaxations. Genetics. Genetic heterogeneity has been associated with GERD. Risk factors: obesity, hiatal hernia, scleroderma, alcohol use, tobacco use, pregnancy. General prevention: decrease consumption of food and beverage triggers such as spicy, fatty foods, alcohol, and caffeine. Weight loss: avoid lying down after meals. Tobacco and alcohol cessation: elevate head of bed at night. Avoid meals close to bedtime. Infants, use car seat for 2 to 3 hours after meals. Thickened feedings. Commonly associated conditions: non-erosive esophagitis, erosive esophagitis, irritable bowel syndrome, peptic ulcer disease, extraesophageal reflux, aspiration, chronic cough, laryngitis, vocal cord granuloma, sinusitis, otitis media, halitosis, hiatal hernia, acid pocket, zone of high acidity in the proximal stomach above the diaphragm. 1. B. Peptic stricture. 10% of patients with GERD, Barrett esophagus, esophageal adenocarcinoma. Diagnosis: history. Typical symptoms: acid regurgitation, heartburn, dysphagia, mostly postprandial. Atypical symptoms: epigastric fullness/pressure/pain, dyspepsia, nausea, bloating, belching, chest pain, lump in throat. Extraesophageal signs and symptoms: chronic cough, bronchospasm, wheezing, hoarseness, sore throat, heartburn, retrosternal burning sensation, regurgitation, sour or acid taste in mouth, water brash. Symptoms worse with bending or lying down. Diet, alcohol and tobacco use. Physical exam often benign but look for potential epigastric tenderness or palpable epigastric mass. Dental erosions. Differential diagnosis: infectious esophagitis, candida, herpes, HIV, cytomegalovirus, chemical esophagitis, pill-induced esophagitis, eosinophilic esophagitis, non-ulcer dyspepsia, biliary tract disease, radiation injury, Crohn disease, angina/coronary artery disease, esophageal stricture or anatomic defect, ring, sling, esophageal adenocarcinoma, achalasia, scleroderma, peptic ulcer disease. Diagnostic tests and interpretation: diagnosis typically is based on history and clinical symptoms. Initial tests, lab, imaging. Indication for laboratory workup depends on clinical presentation. Check for anemia, history of bleeding, or possible poor vitamin B12 absorption due to chronic proton pump inhibitor (PPI) use. Appropriately evaluate patients who present with symptoms suspicious for cardiac disease. Diagnostic procedures / other upper endoscopy. First-line diagnostic test for those with alarm signs and uncontrolled symptoms. 1. B. Indications for endoscopy. Alarm symptoms such as dysphagia, bleeding, anemia, weight loss, recurrent vomiting. Persistent typical GERD symptoms despite treatment with twice-daily PPI for 4 to 8 weeks. Men greater than 50 years with chronic GERD, greater than 5 years, and other risk factors: hiatal hernia, high BMI, tobacco use, high abdominal fat distribution. History of severe erosive esophagitis. Assess healing and check for UGI pathology including Barrett esophagus. Surveillance. History of Barrett esophagus. 50–70% of patients with heartburn have negative endoscopic findings. Esophageal manometry used to evaluate peristaltic function preoperatively and to record lay pressure. Not recommended for primary GERD diagnosis. A second option for those with GERD and normal endoscopy. 1. B. Diagnose motility disorders, functional heartburn, achalasia, and distal esophageal spasm. Ambulatory reflux, pH. Monitoring. Evaluate excessive acid exposure in those with GERD symptoms, normal endoscopy, and no response to PPI. 1. B. Used to document frequency of reflux. Discontinue PPI for 7 days prior to procedure. Barium swallow. Not used for GERD diagnosis. Used to evaluate complaints of dysphagia or to outline anatomic abnormalities. Hiatal hernia. Treatment. General measures. Lifestyle changes are first-line intervention. Elevate head of bed. 1. B. Avoid meals 2 to 3 hours before bedtime. 1. B. Avoid stooping, bending, and tight-fitting garments. Avoid medications that relax less. Anticholinergic drugs, calcium channel blockers. Promote weight loss. 1. B. Tobacco cessation and alcohol avoidance. Limit consumption of patient-specific food triggers. Global elimination of all reflux-causing foods is not necessary, practical, or beneficial. Stepwise approach to therapy. Phase I. Lifestyle and diet modifications. Antacids plus H2 blockers or PPIs. Phase II. If symptoms persist, consider endoscopy. Phase III. If symptoms still persist, consider surgery. Medication. First-line H2 blockers in equipotent oral doses, e.g., ranitidine 150 mg bid, famotidine 20 mg bid renally dosed, decreased dose to 50 mg and for creatinine clearance 50 ml/min. Although less effective than PPIs, H2 blockers given in divided doses provide symptomatic relief in patients with less severe symptoms. 2. A. PPIs. Irreversibly bind proton pump, H+/K and ADPase. Effective onset within 4 days. Omeprazole 20 to 40 mg/day, pantoprazole 40 mg/day, esomeprazole 40 mg/day, lansoprazole 15 to 30 mg/day, dexlansoprazole 30 mg/day, rabeprazole 20 mg/day. No major differences in efficacy among PPIs. Dose 30 to 60 minutes before meals with the exception of dexlansoprazole. 1. A. PPIs may increase risk of hypomagnesemia, hip fracture, Clostridium difficile infection, vitamin B12 deficiency, and community-acquired pneumonia. PPI more effective than H2 blocker and prokinetics for healing erosive and non-erosive esophagitis. 3. A. Erosive esophagitis. 8 weeks of PPI effective in 90%. Re-evaluate symptoms after 4–8 weeks of treatment. Pediatric considerations. Antacids or liquid H2 blockers and PPIs are available. Prokinetics have a minimal role due to safety concerns and limited efficacy. Second-line antacids or barrier agents. Sucralfate 1 gram per QID 1 hour before meals and at bedtime for 4 to 8 weeks, may relieve breakthrough symptoms. Prokinetics. Metoclopramide 5 to 10 mg before meals. Precautions. Blood dyscrasias and anemia with PPIs and H2 blockers. Metoclopramide is a dopamine blocker. Risk of dystonia and tardive dyskinesia. Tachyphylaxis may occur with H2 blockers. Significant possible interactions. PPIs and H2 blockers, multiple cytochrome P450 drug interactions, warfarin, phenytoin, antifungals, digoxin. Issues for referral: persistent or severe disease, surgery/other procedures, laparoscopic fundoplication, wrapping gastric fundus around distal esophagus, increases pressure gradient between stomach and esophagus. Bariatric surgery: surgery indicated if patient desires to discontinue medical therapy, has side effects with medical therapy, has a large hiatal hernia, has esophagitis refractory to medical therapy, or has refractory symptoms. Gastric bypass is preferred. 3a. Manometry to rule out esophageal dysmotility, achalasia, or scleroderma prior to surgery. 3a. Pediatric considerations: surgery for severe symptoms, apnea, choking, persistent vomiting, ongoing care. Follow-up recommendations: patient monitoring, monitor symptoms over time. Consider additional workup and/or treatment if symptoms fail to improve after 8 weeks of PPI treatment. Repeat endoscopy in 4 to 8 weeks if there is a poor symptomatic response to medical therapy, especially in older patients. In patients with Barrett esophagus who would opt for treatment if cancer is detected, perform endoscopic surveillance every 2 to 3 years. Patient education: lifestyle and dietary modifications, eat small meals, avoid lying down after meals, elevate head of bed, weight loss, smoking cessation, avoid alcohol and caffeine. Prognosis: symptoms and esophageal inflammation often return promptly when treatment is withdrawn. To prevent relapse of symptoms, continue anti-secretory therapy, in addition to lifestyle and dietary modifications. PPI maintenance therapy likely improves quality of life more than H2 blockers. Full-dose PPIs are more effective than half-dose for maintenance. 3a. In erosive esophagitis, daily maintenance therapy with PPI prevents relapse. Intermittent PPI therapy not as effective. Medical and surgical therapy are equally effective for symptom reduction. 3a. Anti-reflux surgery: 90–94% symptom response. Patients with persistent symptoms should have repeat anatomic evaluation, endoscopy or esophagram. Some surgically treated patients eventually require medical therapy due to recurrence of symptoms. Regression of Barrett epithelium does not routinely occur despite aggressive medical or surgical therapy. Complications: peptic stricture, 10–15%. Barrett esophagus, 10% adenocarcinoma. Cancer develops at an annual rate of 0.5%. Primary treatment for Barrett esophagus with high-grade dysplasia is endoscopic radiofrequency ablation. Extraesophageal symptoms: hoarseness, aspiration, including pneumonia, bleeding due to mucosal injury, non-cardiac chest pain. Geriatric considerations: complications more likely, e.g., aspiration, pneumonia. References: 1. Patty M.G. An evidence-based